Hello, I'm Dr. Howard Eisen. I'm honored to present at the APCIS meeting. Of course, I'd much rather be there in person with you, but I'm honored to be invited. I'm the medical director of the Heart Transplant, MCS, and Advanced Heart Failure programs at the Heart and Vascular Institute of the Pennsylvania State University Milton S. Hershey Medical Center in Hershey, Pennsylvania. I'm also the chair of the 2023 International Society of Heart and Lung Transplantation Scientific Meeting. And I will discuss the off-label use of the AlloMap gene expression profile testing, but I have no financial disclosures. So the management of patients after transplant is very challenging. It's essentially a tightrope between under immunosuppression, which results in rejection, and over immunosuppression, which can cause cancer, drug toxicities, and infections. These are the causes of death as a function of time in heart transplant patients. So you can see that acute rejection is one of the leading causes in the first year. And this is the alloimmune response, the response of the immune system to the transplanted organ. You can see there's multiple different signals and steps, and our medications inhibit at several places. Here, calcineurin to prevent activation of T cells, steroids everywhere, and here, mycophenolate mofetil and the mTOR inhibitors to inhibit proliferation. But how to determine when patients need to have adjustments in immunosuppression or whether developing rejection is a critical task to managing these patients. This is the endomyocardial biopsy, which has been used for decades to make the diagnosis of rejection using surveillance biopsies when patients are asymptomatic. And essentially several pieces of tissue are obtained from the right ventricle, and they're submitted to pathology for evaluation. And there's a grading system based on severity of rejection. So you have mild rejections, where there's lymphocyte infiltration but no myocyte necrosis, and moderate rejection, where there's a more extensive lymphocyte necrosis, lymphocyte infiltration, myocyte necrosis, and there may be inflammation. And these are the thresholds where we treat. Now, endomyocardial biopsy is invasive. It's not well liked by patients. So the idea of developing an ideal rejection screening test that was non-invasive has become of considerable interest. And ideally, this should be highly sensitive for rejection and adverse outcomes. Negative test strongly associated with good prognosis. Positive test indicates need for treatment or further workup. It's non-invasive, easy to do, frequently on an outpatient basis, low complication rates, and decreased costs. One test that was used early on was something called the Immuno, which measured cell-mediated immunity and T-cell activation. What this is very good at doing is determining whether patients are at risk, over immunosuppressed, and at risk for developing infection. It's not nearly as good for determining whether patients have rejection. And this shows infection, lower scores, rejection, no difference to steady state patients. So there was need to develop another approach. And this led to the idea of gene expression profiling. These are the cells that are involved in causing rejection in the transplanted heart. So there have been several studies looking at this. The very first was the Cargo study, which defined the gene expression profiling test, which is now known as the AlloMap. It was an observational study. Cargo 2, an observational study which basically confirmed what was observed in Cargo. The IMAGE study, which is a randomized trial of management of patients using biopsy versus gene expression profiling from about 6 months post-transplant onward. And then the EIMAGE study, which was a study similar to the IMAGE study, except looking at patients within the first, starting from the first 60 days post-transplant. Again, we've seen this. The immune pathways that cause rejection. So the cargo study involved 629 patients and almost 5,000 post-transplant encounters. And the hypothesis was that gene expression profiling of peripheral blood can discriminate ISHLT grade 0 rejection, no rejection, or quiescence from moderate to severe rejection, ISHLT grade 2R. And it was prospective blinded validation of a 20 algorithm, gene algorithm, to determine whether grade 3A or 2R rejection could be distinguished from grade 0. So this is the steps. Initially, there was a microarray that was done to identify genes whose expression changed as a result of rejection. And that's shown here. There's a heat map. These are the genes whose expression is upregulated. These are the genes whose expression is downregulated at the time when there's a 2R rejection versus no rejection at all. After that, an algorithm was developed, and patients were then, samples were obtained from patients of either grade 0 or grade 2R. And then there was a validation study looking at all patients in the centers, the 8 transplant centers involved. And these are the genes that were identified and included in the AlloMap. There are 11, then there are 9 what are called housekeeping genes, genes whose expression does not change with rejection, so they're internal controls. This shows the various different genes. So you can see they're not just T-cell genes. They're involved in inflammation, mobilization of hematopoietic precursors, and more specifically rejection, cell migration. Ultimately, what was found was that gene expression profiling or molecular diagnostic testing could significantly distinguish grade 3A, also known as 2R rejection, versus 0. Low scores had a very low risk of rejection, grade greater than 2R or 3A, with a negative predictive value greater than 99%. So what that means is that a screening test was developed to determine if patients needed biopsies or not. But that's not all. There was a central pathology core of very eminent pathologists who reviewed all the biopsies and compared them to the local pathologists from the transplant centers. And they found that with moderate rejection, 2R or greater, they disagreed with the diagnosis of rejection 62% of the time. They believed that there was overdiagnosis of rejection. And so biopsy is not really a great gold standard. As a result, thousands of patients have received the AlloMap as a screen for rejection, and in the United States, over 80% of transplant centers use it. When I was at Hahnemann, we implemented this very early on in 2005, perhaps the first center in the United States to do this. So we would obtain, we would examine patients who were stable, get echocardiograms, check the molecular diagnostic test, the AlloMap, and if the score was above threshold, and threshold is above 30 in patients within 6 months post-transplant, and beyond that, above 34, we would get a biopsy. If it was lower than threshold, we would not. These are all the subsequent studies involving the development of the AlloMap. An important study was this one published in the New England Journal of Medicine and led by Mike Pham, the IMAGE study. So 13 centers, non-blinded, randomized and stratified, non-inferiority from 6 months and beyond. It was driven by outcomes, and these were the endpoints. And this is the randomization. So almost 300 patients got the AlloMap gene expression profiling to guide their therapy. A little bit over 300 got endomyocardial biopsy. The vast majority of patients were enrolled in the study at 1 year and beyond. And this is problematic because most rejection occurs within 6 months post-transplant. So this was missing the key period of time when patients get rejection. There was no difference in outcomes, no difference in survival. Next study was the EIMAGE, or early image study, which looked at patients from 2 months post-transplant and onward. So basically, they looked at people when rejection was most likely to occur. These are the issues with the IMAGE trial. Most patients were 12 to 60 months post-transplant, and the EIMAGE study was started at 55 days post-transplant. Similar endpoints. They also added an IVUS endpoint, and they also looked at the ability to wean corticosteroids using gene expression profiling. So this is how EIMAGE differs from IMAGE. And it's a small study. 30 patients were in the gene expression profiling, 30 patients in the endomyocardial biopsy arm. These are the clinical events, the randomization scheme. So again, if the score was above threshold of 30, patients get a biopsy. Below threshold, they would not. And there was no significant difference in the endpoints between the two groups. No difference in event-free progression. And there was a very high negative predictive value. And even if you have an elevated AlloMap score, you are unlikely to have rejection. So there's a low positive predictive value. Both approaches, gene expression profiling and endomyocardial biopsy, allowed weaning of corticosteroids. So these molecular diagnostic tests can be used to wean corticosteroids. Cargo 2 was a study done mainly in Europe, and otherwise very similar to Cargo. And what they found was that they confirmed that that the AlloMap test had a high negative predictive value and a low positive predictive value, as was found in Cargo. They also found that endomyocardial biopsies had limited utility. 1/3 of biopsies assigned grade 2R or more were agreed upon by pathologists. But as with the Cargo study, 60% of biopsies greater than 2R, the central pathology group said that they did not have rejection. So once again, rejections being overcalled. And so this demonstrated again the limitations of endomyocardial biopsy. So discouragingly, ISHLT grading is least objective when trying to fulfill one of its main purposes, detection of severe acute cellular rejection, and most objective when trying to prove a negative result, absence of acute cellular rejection. Thus a very limited test. And as a result of these studies, the 2013 ISHLT guidelines gave this level of evidence B and class 2A indications. Another way to use the AlloMap is to look at variability, intrapatient variability. So for example, this patient here, very stable scores. This patient was stable clinically. This patient had scores all over the place, much less stable. And also, there is evidence that the gene expression profiling can predict future adverse allograft events, specifically rejection. So variability may be a useful way of determining outcomes in patients post-transplant. Another interesting observation from the IMAGE study was that there are patients. They looked at one group of patients with the lowest quartile scores of patients who were below the threshold, and then the other 3 quartiles were looked at in the second group. And what they found was that the group with the lowest gene expression profiling scores were least likely to have rejection and least likely to have any adverse events, and were less likely to be on steroids. So this is an immunoprivileged population. It indicates that these are patients in whom biopsies don't need to be done and immunosuppressive weaning can be done. And one interesting observation about this population was that they were much more likely to be donor and recipient negative for cytomegalovirus, which is a common post-transplant infection. So these, and this is the summary of what I just discussed. Robert Scott and his group at Mayo Clinic Scottsdale were studied using the AlloMap to wean mycophenolate and steroids, and they were able to successfully wean prednisone using the AlloMap in place of endomyocardial biopsy. And they had a 52% reduction in endomyocardial biopsies. Some caveats: gene expression profiling has not been validated within the first 55 days post-transplant. Its use is limited to stable patients and cannot be used within 3 weeks of high-dose corticosteroids, for example, what's used to treat rejection, because there are several genes in the algorithm that are steroid dependent, and high-dose steroids will limit their utility. Another approach would be to use donor-derived cell-free DNA. So cell-free DNA is released from healthy, inflamed, or diseased tissue cells undergoing apoptosis, programmed cell death, or necrosis. And this cell-free DNA can be extracted and can be quantified. And it's released from all sorts of different organs. It's been used in certain circumstances outside of transplantation. Its first indication was for the non-invasive diagnosis of trisomy 21 Down syndrome. So blood tests can be used to look at that, or as a liquid biopsy to monitor cancer genetics in the blood in patients with metastatic cancer, and then finally in solid organ transplantation. And here's how that works. So without rejection, there are low levels of donor-derived cell-free DNA because the allograft is stable and not damaged. When there's rejection, allograft cells are damaged. And so there are increases in release of donor-derived cell-free DNA, and that's a marker of rejection. So there have been a number of studies looking at this. Cargo-2 and a kidney study, Cargo with a K, there were blood samples banked, and they were used to look at donor-derived cell-free DNA. And what was found was that with rejection, the donor-derived cell-free DNA was elevated compared to quiescence. So here's an example of how donor-derived cell-free DNA changes. Immediately after transplant, there's elevations in donor-derived cell-free DNA, but they reach basal levels by 2 weeks post-transplant. Here's a patient who developed a 3R rejection and had a rise in their donor-derived cell-free DNA. And this shows the relative scores. So here's a patient who developed rejection. Scores are elevated, treated for rejection with corticosteroids, and the scores come down. So this test can even be used to look at the presence of rejection in response to therapies. This is another example comparing quiescence to rejection from the Cargo-2 study, showing a difference in scores. And this shows also a difference in scores between rejection and quiescence. And donor-derived cell-free DNA correlates with treated rejection in patients, in heart transplant patients. So these are patients who were subsequently treated, and these are patients who are quiescent. The other interesting thing is that donor-derived cell-free DNA tends to increase about 1 month prior to rejection. So this may be a way of monitoring the ultimate development of rejection and adjusting immunosuppression to prevent rejection. But here's the classic example. With rejection, there's damage to cardiac myocytes in the allograft, release of donor-derived cell-free DNA as a result. This can be detected, patients can then be treated, and the donor-derived cell-free DNA levels go back to baseline. Again, another example, 2R rejection, increase in donor-derived cell-free DNA, and a reduction with treatment with corticosteroids. In the kidney study, small numbers, similar observations. So you would expect to see this phenomenon of the rise in donor-derived cell-free DNA in all solid organ transplants. So here's an example in the kidney with rejection, a wide span, but a rise in percentage donor-derived cell-free DNA, and similar to rise in creatinine in patients who are developing rejection, kidney transplant patients. And immediately after transplant, the levels are high, but within 2 weeks they come down to the baseline. As we saw in the hearts, with treatment of rejection, donor-derived cell-free levels come down. And these are the basal levels of donor-derived cell-free DNA in liver transplant, kidney transplant, heart transplant. So again, a picture diagramming cell-free DNA, normally small numbers when there's no damage to the allograft. When there's acute cellular rejection, there is damage to the allograft. You can remember, no doubt, the earlier pictures I showed, which really showed that there was damage to the allograft, and that leads to release of donor-derived cell-free DNA, which can be quantified, and that can be used as a biomarker of presence of rejection. Here's an example. The percent of donor-derived cell-free DNA rises with 3A rejection here, 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 and here. And there's some evidence that another disease that damages the transplant heart, cardiac allograft vasculopathy, or the transplant coronary disease can cause a rise in donor-derived cell-free DNA, which makes sense because that causes injury to the cardiac allograft. So this again shows what we're looking at here. And then more data. We saw this, the 2R rejection, 2R, 3R in here, and rejection. And so with treatment, the results come down. And this also works for detecting antibody-mediated rejection. Here's an example. Another form of disease that can be that can cause damage to the cells of the transplanted heart and can result in a rise in donor-derived cell-free DNA. And I think we saw this sort of stuff before. Limitations are a small number of rejection samples, biopsy histology, imperfect as a reference standard for the diagnosis of rejection. So retrospective analysis and other causes of acute allograft injury were not studied. So but it may be a helpful test for identifying injury to the allograft from acute cellular rejection, antibody-mediated rejection, or cardiac allograft vasculopathy. As it's not organ-specific, other solid organ transplants like liver, lung, kidney, as well as combinations like heart-kidney, could result in elevated donor-derived cell-free DNA. So to look into this further, there's the SHORE study, it's a registry, multi-center, where samples are analyzed by gene expression profiling in donor-derived cell-free DNA, and the results of those are compared to outcomes such as acute cellular rejection, antibody-mediated rejection, development of cardiac allograft vasculopathy, mortality, and need for retransplantation. So the hypothesis is that donor-derived cell-free DNA is a marker of injury. And so whether you can identify those injuries or not is still unknown. So again, we saw this donor-derived cell-free DNA increases with 2R rejections here compared to quiescent. Now in spring 2020, a highly contagious novel virus with respiratory spread and mortality higher than seasonal influenza is upon the land. Hospitals and ICUs are filling up with the sick. The virus is spread by asymptomatic infected individuals. As this is a novel virus, in spring 2020, there was no vaccine or antiviral agents that were known to work. And fortunately now we have effective vaccines and effective drugs. The sequelae of viral infections are more severe in those with underlying cardiovascular disease and comorbidities. And the outcomes of infection with this virus in immunocompromised is unknown, but we have experience now that it actually can be quite severe. But it was quite clear nothing can come from this. So our goal was to minimize exposure of heart transplant patients to crowded settings and places where they could be exposed to the virus, such as hospital corridors, waiting rooms, catheterization labs, clinical labs, and recovery rooms. So recent cardiac transplant patients require endomyocardial biopsies in the first 6 months post-transplant. And beginning at 55 days post-transplant, you can use the AlloMap, the gene expression profiling test, to determine if patients have 2R or greater rejections. You can also, beginning at 2 weeks post-transplant, use the donor-derived cell-free DNA, which is also known as the AlloSure. So our goal was to try to minimize exposure of our patients to virus while maintaining surveillance for rejection in new heart transplant patients. So what we did was we arranged for home blood draws of the gene expression profiling test, the donor-derived cell-free DNA, and immunosuppressive agent levels, chemistries, and CBCs. And the result of the gene expression profiling test was to determine whether patients needed to undergo endomyocardial biopsy or not. And the thought is that doing these tests in the patient's rooms would help minimize contact between patients and the viruses. And we actually did have a pre-existing program for obtaining blood tests at home from our patients. And we also can get routine blood tests, CBC, chemistries, immunosuppressive medication levels, and they were added to subsequent gene expression profiling tests obtained by us. So this tells where we are. This is Hershey, Pennsylvania. Philadelphia is here. Pittsburgh's out here. And our patients live all along here. So they're pretty widespread. But our approach using this remote monitoring was very helpful. You saw the slide before. This is the validation of the original cargo study. So the grade 2R was significantly different in terms of result of molecular diagnostic testing compared to the grade 0 patients. So 10 gene expression profiling tests in June 2020 were obtained with institutional in-house mobile testing programs. 10 obtained HeartCare, which is the combination of gene expression profiling, or the AlloMap, and donor-derived cell-free DNA. And so this was obtained with the institutional in-house mobile testing. We subsequently used a commercial approach with RemoTrack, which is owned and run by CareDx, which makes the gene expression profiling tests. There were no honoraria for this or anything. So 3 patients obtained HeartCare as a result of this RemoTrack I mentioned. And because of low AlloMap scores, 25 endomyocardial biopsies were prevented, 32 visits to labs were prevented, and none of the patients transplanted in 2020 developed COVID-19. So donor-derived cell-free DNA obtained remotely can provide guidance as to which patients have evidence of myocardial damage and hence need further evaluation, such as endomyocardial biopsies, coronary angiography, to detect causes of myocardial injury and antibody-mediated rejection, acute cellular rejection, and cardiac allograft vasculopathy. So remote testing as with telemedicine, may become a part of routine care. The advantages would be convenience and minimizing exposures to infectious agents. And pandemics provide inspiration for innovation and creativity. So I'd like to thank you for inviting me. Kamsahamnida, and have a good rest of the meeting. I'll be tuning in periodically.